Next, we have Dr. Pushkar Dhir, Efficacy of PFCL flap, inverted ILM flap technique for treatment of chronic macular hole.
A very good afternoon, everyone. So I'll be talking on the modified inverted ILM technique versus the normal inverted ILM technique in cases of chronic macular hole cases. Before I start, I would like to acknowledge Dr. Chintan Desai, who is also here in the room, who has persuaded me to try this technique when I was facing a lot of macular hole closure failure. So going on to the technique which I'll be discussing, there's no financial closure. So as we all know, that inverted ILM technique was well started by Michalowski et al. In 2009. And in the method, ILM was not completely removed, but a small remnant was left at the edges. And multiple studies have reported a superior result as compared to the conventional technique where the whole ILM was removed from the whole edges. So ILM flap technique is limited by difficulty in maintaining the inverted ILM flap inside the hole during the FAE, fluid air exchange, and with high rate of accidental ILM flap detachment during the procedure. Though we all try to do it with a minimum of vacuum, but still there is chances of iatrogenic removal of the flap itself while doing the FAE. So my aim was to evaluate the efficacy of modified inverted ILM technique versus the normal ILM technique, and we did it at Eye Care Center in Bhiwani, Haryana. The study design was retrospective interventional study and did for 2 years. In this, 11 eyes of 11 patients underwent the standard 3-port 23 gauge vitrectomy. And in this procedure, after folding of the ILM, what we do in a conventional, inverted ILM technique, approximately 3 ml of PFCL bubble was injected over the ILM flap, forming a PFCL cap. And that helped in retention of the flap inside the macular hole during fluid gas exchange. The preoperative and postoperative visual acuity were measured at 1, 3, and 6 and 12 months. And the results were really good after this study, which I'll be sharing subsequently. So quickly moving on to the technique which we did. So after the conventional PVD induction and the staining of the macular hole with the BBG and the normal inverted ILM flip technique is being done. So once we have peeled off the ILM in an inverted fashion, even if you are not able to invert it properly, still, if there is even a flea flap, you have to put a PFCL bubble, lower the IOP, and then put a PFCL bubble, and whatever flaps are there inside the vitreous cavity, just drag on the flaps from the side into the macular hole itself, and you will see a closure of macular hole on table itself. And then you have to carry on with the FAE gradually. These are the 2 cases which I have shown over here. So you can see that in both of the cases, you can see the ILM put inside the hole, and the hole has a closure on table. So 11 eyes of 11 patients were included, out of which 33% was females and 67% were male. Majority of the patients were in the age group of 50 to 70 years, with minimum linear diameter of macular holes was 811.4 microns. Preoperative visual acuity was 1.2 logmar. Mean postoperative visual acuity after 12 months of surgery was 0.56 logmar. The statistical analysis confirmed that there was a significant difference in the visual acuity between the preoperative and the postoperative results. So we confirmed that the closure of the macular hole with spectral luminosity was, in this case, were 100%. The closed macular hole had a better configuration. It was U-type rather than the V-type, and there was significantly increase in the visual acuity also. So these are the different cases where we have done the same technique. The discussion part, the present study observed that the mean postoperative value in these cases were significantly improved. According to Michalowski et al., there was high rate of accidental ILM detachment during inverted ILM technique. Our study also found the closure rate of macular hole by this technique was 100%. And our study demonstrated that closed macular hole has a U-shaped closure which is associated with good visual vision. Conclusion, we present a modified ILM flap technique to improve retention of ILM flap inside the macular hole and improve the reliability and reproducibility of the operation itself. The limitation is that we have a small study till now, and we'll be continuing it further also. So thank you everyone for patiently listening to this talk.
So, one of the cases you showed free flap.
Yeah, so if there is even a free flap.
So, are you stuffing that in the macular hole or just the PFC?
No, we
You're
stuff it,
stuffing.
yeah.
Because there is always a chance of
Sucking
dislodgement of this flap when you are removing the PFCL bubble as well.
Okay, so once you start removing the PFCL, so what you do is, once you have put a PFCL bubble, you have removed the flaps and put it inside the hole. Then you start doing the FAX, you keep the fluid needle over the disc. So gradually, once the last portion, only we are worried about the last portion when the dislodgement occurs. So if you keep it slow, I mean, you keep the pressure low and you keep it slow, you will be able to see that there is no dislodgement. And you have to keep it for 25 to 30 seconds, not that immediately after putting the PFCL bubble and stuffing, you start removing it. So that will can lead to any dislodgement, but it didn't happen in my case. So it all depends how you move the ILM towards the hole and put it inside.
So, in any cases you had the subretinal migration of PFCL bubble?
No, not yet. Not yet to be documented till now.
As well.
Yeah. Definitely, there's a possibility.
Dr. Pushkar, I'm still confused about the last part of it. So you start fluid exchange.
Yes.
Then your flute or whatever aspiration backflush is at the disc.
Yes.
Now when the air reaches, until the air reaches the PFCL, it's going to be a round bubble, right?
Yeah, correct.
The moment the air is going to touch the PFCL interface, you are going to lose the contour of the air bubble, the PFCL.
Yeah, the contour will be lost.
So you won't be able to make a difference between the remnant fluid and the PFCL. So my question is, again to the basics,
remnant PFCL,
the remnant PFCL and the remaining fluid is going to mix. You won't be able to make it a difference between both, right? So how does the last part is crucial, and exactly during the last part, your PFCL and your fluid become one. So how is your PFCL helping? How is it different than doing a conventional technique? I hope you got my question.
Yeah, basically the question is about the PFCL mixing and the losing its property of the tamponading, which was already there. So once it touches it, even still that the contour is lost, still the effect is already there. The PFCL has done its effect already. The moment, the time you have kept it inside and done whole the procedure, the PFCL has impacted it. It was supposed to put the pressure on it, it has done its job well. And once you start removing it, it doesn't move.
Okay,
Thank you.
Thank you. Can we have the next speaker?
Pushkar, 1 second, I have another question. So, more than a question, rather, is just a comment.
Yeah.
First of all, it's very nice what you presented. Thank you for sharing it with us. Now, one correction is that you don't really achieve closure on table.
Sorry?
You don't really achieve closure on table. You're just stuffing the ILM. See, ILM is just a scaffold.
Yeah.
So you're not going to get closure by any chance. Even if you don't stuff it, in fact, it's not recommended that you stuff it in the first place.
Okay.
You just leave it attached, and it'll just pick up as a scaffold. And
it will just...
Correct, that's one.
Yeah.
Second, you should also look at why you're getting so many hole closure failures, like you said, because the peel that you showed was a macular excess kind of a peel. Go all around.
Correct.
What I would also suggest is you can start doing something like a 180-degree quadrant, or do it in quadrants, so that you have a residual flap which you're not going to inadvertently peel off. You get my point?
Okay.
So, for example, you come about
make it
180 degrees.
quadrant-wise.
You do a 180 degrees. That's quite simple. And then do a 180 degrees, and then you have a residual attached area. It's very unlikely that you're going to. I've never had a flap that I've dislodged.
Okay.
So it's not very common.
So you do it for 180 degree only?
Yeah, you can do it to 180 degrees. You can do it for smaller quadrants also, so that you make sure that multiple places it's attached to the whole edge. So, and the residual you can remove or just trim it.
All right.
Okay.
I'll try to take it. Thank you for the comment.